Cast is now starting. All attendees are in listen-only mode.
Hey,
Hey,
Mark,
Mark,
I'm
you're
gonna
going to
go
go
ahead
ahead and make
audio.
Hey, Nicole, can you hear me? Hey, Nicole, this
Yes,
Mark.
Yes, but I'm having some background.
I think it's because I'm on my phone and computer.
Okay. I'm getting a lot of feedback from you on my end. Let me see. Okay.
It's not your fault. I think I'm on the phone and the computer.
That could be the reason. Okay, which one do you want to go with?
I'm going to go with the phone because
Okay.
that's probably going to be clearer for them to
Yes.
hear.
It does. It sounds much better from what I was hearing before. So that is good. Okay, let me see here. What I'm gonna
But then
do.
if you're actually, I just muted out the phone. So I'm just going to go ahead and hang up real quick and let's see if the computer is good.
Okay, that sounds
Give
good.
me a second.
Whatever you want to do. We still got some time.
Okay, so now can you hear me good?
I can hear you just fine. Just perfect.
Perfect.
Okay.
With that.
Okay, what I'm going to do is I'm going to do about 10 slides, just very quickly go through these, and then I'm going to turn it over to you right here. So it'll be my stuff will take about 5 minutes to get me to you. And then what we're going to do is, let's see here, give control of the keyboard and mouse to attendee. Let's see, make another attendee the presenter. I'm going to click on this button and see if it will work. See if I can move it to you. Let's see here. Nicole, there we go. Okay. Are you sure you want Nicole to be the presenter? I'm going to say yes. Okay. Now you should have control of everything. You want to put up your presentation there and see. Oh, there you are.
Okay, can you see the PowerPoint?
I see a bunch of pretty people. Some good looking people
Let me
there.
go and put it on my screen just because I have so many screens. That's why I just want to make sure. Now you can see it.
I see. Yeah, it's coming up now. Yep. There you are. CDS, Chronic Disease Solutions, and if you hit slideshow,
And
it's sort of buried in there. You're very close to it. Where's this?
it's showing a network. Can you, hold on. Can you see?
I see it says agenda, but if you go into where it says slideshow and for the whole screen, it will end up looking
Right.
better, I think.
Okay, I just wanted to make sure you could see. So I'm going to be on screen. Okay,
Yep.
I'm going to be on my
You're good. You're good to go. So that will work. Let me see here. Wonder if let's see if we hit that. Okay. Make another attendee presenter.
Let me
Okay.
just see if I can move to, I'm going to try to move you to, hang on one second. I'm going to try to see if I can move
I've
you
done
to
that.
monitor.
I can turn. What I will do is turn off that. People don't need to see me anyway, so I can turn that off, and in that way, that'll be.
Okay, let me ask you, which one what are you seeing right now?
I'm seeing your email.
Okay, perfect. Okay, so I'm going to move you. You must be on monitor 2. Okay, tell me when you could see the agenda again.
Okay, not yet.
Are you seeing pictures?
I'm seeing pictures.
Okay.
Now I see the agenda.
My screen. Okay, perfect. Okay, you'll be able to go with this one. Okay, perfect. Okay.
Okay.
Good.
All right, we're good to go then. All righty. Let's see here. Yeah. Just if you'll do that from beginning, then it should be the full screen there.
Yeah.
Yeah.
Yeah, and then I'll go.
Okay. Perfect. Okay. Perfect. All right.
So you can see the front page, right? You cannot
Yep,
see
that's
it
what I see. You should be able to. There's a little arrow down in the corner here. If you just click that, then you can just go forward as you go. You should have complete control.
I'll control it on my second screen, so then they won't even see it. So it'll be good.
Okay.
Like, see, you can see it.
Perfect.
Okay, perfect. Yeah.
Okay. Okay.
Okay, got
All
it.
right. Good deal. We'll do that switch over about after 10 slides, and then we'll be ready to go.
Good to go.
Good.
Awesome.
Good deal. And then we have for the seminar in Alabama, we have about 30. We're right at the max. We're at 30. The place where they're doing it
Awesome.
is very small apparently, and Rob is like, Mark, you cannot get more than 30 people in there. And I was like, we can try, can't we? he's like you are not gonna get any more than 30 people in that room. So we're right on the verge of standing room only at this point. So that's good. That is good. Okay. Oh, let's see here. All right. What I'm going to do, if you don't
It just
mind.
an command. Yeah, you can take it back because it just went on my command. I told it to, and I wasn't talking to it. I was talking to you, and it shifted my slide.
Okay.
Okay, you want to take it back? Want me to go?
I'm gonna take back over then and show my screen. Okay, good. Okay, this should be easy then. Let's see here. Oh, and when I showed my screen, I had your stuff up. So, all right. So, all right, and then we will. Let me see here. I've already sent everybody the handout, so I'm gonna hold off on those, and then. What time we got here? 2 o'clock. So we got 15 minutes where we start. So I'm going to work on a little bit of other stuff until 2
Yeah, that's what I'm going to do as well. So,
and then we'll get it started. But everything's working fine, so that's good.
Awesome.
Okay.
Good.
We will talk to you in 15 minutes then.
Okay. Thank you.
Good afternoon, everybody. It is 2:15 according to the clock on the wall, so which means it's time for us to begin, excuse me, our chronic care management in Rural Health Clinics webinar, 2:15 Eastern Time, March the 7th, 2019. This session is being recorded. So thank you guys for attending. This is going to be a joint venture between Chronic Disease Solutions based in Louisiana and Healthcare Business Specialist based here in Chattanooga, Tennessee. My name is Mark Lynn. I'm a CPA from Chattanooga, Tennessee, and there is my contact information. And Danny Gilbert, who is not with us today, she's on vacation this week. But if you do have to get cost report information to us, either of our phone numbers or emails will work. I know it's that time of year when I've been sitting here working on cost reports while we wait to get this thing started today, because it is that time of year when we are very busy. If you have not joined this Rural Health Clinic information group exchange, we have well over 600 members, and we try to answer your questions regarding RHCs. We provide information about different seminars and webinars that are going on so that you guys can keep up with what's happening with your rural health clinic and the management of your RHC. We also have a YouTube channel there. It's not the most exciting thing in the world, but we will post recordings like this one here. Once we get it finished, it'll go onto our YouTube channel so you can watch what Nicole has to say on that if you missed it, or if you have other people that need to hear this information, you will have access to it. We also have a newsletter that we send out, so if you will sign up for our Constant Contact newsletter, we will get those out to you as well. If you're in Alabama, Nicole will be there with us, in fact, and we're going to do a free seminar for the people from Alabama. If you're not in Alabama, don't sign up. We're not going to have room for you. We only have slots for 30 people right now. This is a free thing. Rob Boyles has agreed. He called me up 2 or 3 weeks ago and says, Mark, can we get some people to do this webinar, the seminar? We have some money to spend before the end of the fiscal year, which was March 31st. And so I was like, sure, I'll be very happy to help you spend some money And so they're being very kind and offering a free seminar on billing for the folks in Alabama. So if you've not signed up for it yet, do so very, very quickly, because you will. You're going to need to be, you're going to get in quickly, because it's going to get cut off very shortly. So when you know that, what we do is we prepare Medicare and Medicaid cost reports. So if you guys, it's that time of year when, if you don't have your Medicare cost report, somebody to do that, let us know. We'll be happy to add a few more to the 150 that's in our stack here. We've hired our poor little interns that are juniors in college in accounting, and they're learning as fast as they can to help us put these things together. It is quite an ordeal this time of year. But we do annual valuations, startups, and then we help you guys with billing as well. We do lots of TennCare quarterly reports as well. Danny does those very well. Disclaimer, this is being recorded, so if you don't want to be recorded, then please hang up. Information is current as of today, as far as we know. We won't be providing information on specific situations, but Nicole will go over generally what is allowable as things that you can bill and what you will get paid for under the chronic care management guidelines, which have changed pretty regularly. Every year they will go through and sort of tweak it. It started about 3 or 4 years ago, and Medicare is learning how to do this process as they go along, and they've changed things. So it's been one that's hard to keep up with. If you do have questions, you can type those in over there on the question bar, or if you want to, we'll save a little bit of time at the end, and Nicole can answer questions. And if you raise your hand, I will go in and unmute your line so that you can ask Nicole your questions there. So here's Nicole's information here. The company called Chronic Disease Solutions. We've had very good luck with them. They work with some of our clients and have been doing a fantastic job with them. They've not been billing for dead people. We had one company that was working with us, and we found out they were billing for dead people. So that didn't really go over too well. So here's Nicole's information here. And what I'm going to do at this point is turn it over to Nicole without further ado. And now I have to remember, make another attendee presenter. And Nicole, it is coming your way. So you are now in charge. We should be able to see your screen in 2 seconds. 1 second. There we go. There you are. So your screen is showing now, Nicole. You are in charge of the webinar.
Thank you, Mark. Good afternoon, everyone. I know the agenda looks pretty lengthy, but I'm going to go through it pretty quick. I just mainly wanted to have this included in one presentation so that you guys can refer back to it if and when you do have questions, or feel free to reach out to Mark. He'll forward them to me. Or at the end, you'll have my contact information. You can send me an email if you ever have any questions. Regardless if I'm working with you or not, I want to help. I've been in healthcare for over 25 years, and I eat, sleep healthcare. So I'll get started a little bit. What is chronic care management? As Mark was saying, chronic care management has been around for, I think, since 2015 it started. So it has had several challenges since then, but it has changed, and it actually has improved since then. Basically, at this point in time, they actually reimburse the rural health clinics versus the non-rural health clinics on several different codes, and it's different reimbursements because the non-rural health clinics are able to make additional codes. This is a little bit about the program requirements. You have to obtain a consent. It could be verbal, and so we assist with our providers with getting that. So basically what you can do is you can enroll the patient over the phone, but what we do for our providers, we always mail the actual consent to the patient so that the patient doesn't forget later on that he or she consented to the program, and actually they have something to reference later on. So the patient must have 2 or more chronic conditions, and I'm going to show you just a a quick list of those chronic conditions, they continue to add to them. So I always tell my providers I would prefer you to enroll the patient and assume the patient meets the criteria rather than not enrolling the patient. And then we take it from there. You can kind of see this is about 60 plus, but they have a lot more. The other thing is you have to have it, I know, and I'm going to go into it right now. So the billing specifications, only one provider is allowed to bill for it. Sometimes we have found that there are several providers that are offering to their patients. Well, if that happens, we go ahead and we both bill it, but whoever files their claim first is the one that's going to get paid. So once that happens to our providers, hang on one second, let me just slow this down. I'm not talking fast enough. Give me 1 second. See if I can slow it down. This is going quite fast. Okay, I think I've got it. So what we have done for our providers is we want to make sure that they are the provider of choice, and yet they are reaping the benefits. So not only they're going to offer this, we call it the concierge service for their Medicare population, we want to make sure they do get reimbursed for it. So if in fact we do bill for the chronic care management service and it is denied because another provider is providing the service and did process the claim and got reimbursed for it, what we do is we reach out to the patient and let the patient know that they're only allowed to participate in one of them. And we do try to encourage them to stay with our provider, but again, the patient has the choice. So that is what we do for our providers, so that we can lessen the chance that the provider is offering the service and not getting reimbursed for it. The other thing, you're allowed to bill chronic care management with any date of service. So sometimes, for instance, a claim will be submitted with a date of service, let's just say today, March 7th, because that may have been the date that the biller entered it in the spreadsheet or entered in the claim or submitted, the super bill. And CMS says you are allowed to do that as long as the time is met. We do try to focus on putting the date of service the last time the patient was touched and or the second the patient met his or her time, if we are following the claims for our providers. So the data service can fluctuate. So if you find out from another vendor or you're offering chronic care management yourself and you say, well, no, I put all the last day of the month, you are allowed to do that as long as the time is met. So that is just something we do on our end as a preference, but you can use any date. There are some exclusions on the list. Home health. So if these specific codes are being processed at the same time frame or includes the same data service that you provided for your chronic care management super bill or claim, it will be denied. Does it mean that the patient is now not eligible? Because sometimes the patient is only receiving maybe some some temporary home health services or some temporary hospice services. So we don't necessarily revoke or opt out our patients who are receiving those other services. What we do is we continue to provide the service and services at time. We do not bill our provider for the time that we spent with their patient at that time because we know that they're not going to get reimbursed, but we still want to make sure we're servicing their patients. So just keep in mind there are a few exclusions, but doesn't mean that the patient is not eligible. Always get asked, what counts towards the 20 minutes? Basically, anything counts towards the 20 minutes except for the time that it's for conducted by your biller, maybe your billing department, it could be someone administration. All those services do not fall underneath the CCM billable services. And I'm going to kind of go more into detail about that because that seems to be a lot of confusion on that. So even when you are sending resources to the patient because maybe the chronic condition is diabetes and you discuss diabetes, but you always have to follow it up with some resources, some actual hard copy material so the patient has something else to refer back to later on when he or she is either in question, confused, or needs something to refer back to because they're faced with something that they believe that might have something to do with the chronic condition of the diabetes. So all that time is billable, but the time that it takes for you to enter in that claim or enter in that super bill, not billable. That is not billable service. You still need to do it, but it's just not billable. Who can provide CCM services? Physicians, physician assistants, nurse practitioners, a nurse specialist. So I kind of listed out who falls underneath that. Who's not eligible? Providers, the dentist, podiatrist, psychologist, those can contribute to the time that you bill for CCM, but they can't actually be the billing provider. So their MPI cannot be utilized for the CCM services. Who can perform billable CCM services? We get this question quite often. What is considered clinical staff? CCM says, and I've been through an audit, well this year, but back in 2016 when we were all in that gray area. What is considered clinical staff? Does that mean anyone that works in the clinic? Well, no, that doesn't mean that. But it does include these. And I do have where I kind of fought the audit and we did win. So I am pretty confident in this list. This is the clinical staff individuals that CCM recognizes as being able to perform the billable CCM services. Medical assistants, again, every state is different. Whatever your state requires. So if you're providing CCM services yourself for your patients, then you are required to comply with your medical assistants or any other clinical staff listed right here must comply with your state regs in order to classify. So if you're using an outside vendor for your CCM services and they are located in, let's just say, Louisiana, we have to comply with our state in regards to what is classified as a medical assistant. But that doesn't affect, so if we're providing the CCM services out of Louisiana for a Tennessee clinic, which we do, we are actually required to comply with the state of Louisiana regulations for a medical assistant, but comply with the state regs of Tennessee as it pertains to the CMS and the CCM providing the actual, like being able to perform as billable services. So those two are a little different. So the nurse practitioner or the provider that's in Tennessee must comply with the regs that I just went through right here, based on their state. Right here is based on who's ever performing the CCM services. So I hope that kind of explains it, because some get it confused. Just because your clinic is located in Tennessee and the CCM services is provided by another state, you don't have to worry about the Tennessee regs on whoever's performing it. Your vendor or your outside CCM service is required to comply with those. Please stop me if you have any questions, because I'm sure it's not a question I haven't been faced with, especially in regards to this. Who can perform non-billable CCM services? This is what I kind of mentioned earlier: the billers, your office manager, your receptionist, your scheduler, or any other administrative staff. Can a provider outsource his or her CCM services? Yes. So what I kind of go into right here is it's billed incident 2, but it's billed underneath the provider's MPI. So it's not like it's your CCM service vendor is billing underneath a separate provider number. It's not. It's actually billed underneath that provider's number, and it's just incident 2. Now, incident 2, the only thing that's the exception when it's in regards to CCM is right here. So the incident 2 rule is usually direct supervision with the physician or the provider being in the clinic. The exception for CCM in regards to the incident 2 rule is it's general supervision. So the physician or the provider doesn't need to be present, which is the reason why you can outsource your CCM services. Your CCM vendor can be located in any state and still provide this to your patients, because that's the exception to the rule as it pertains to CCM and the incident 2 rule. Who are we? We're Chronic Disease Solutions. Kind of like Mark just said, we do work closely with Mark. We've had the privilege of working with him for the last several months. No, and I would have to say we definitely try not to bill for any dead patients. We do know sometimes there might be a lag. The patient may pass away, and there was a care plan done, and so the patient, there was a claim submitted based on the date of service being after the patient has passed away. If that happens, if it should ever happen, what we do is we write it off on our end. Again, our providers are never, ever invoiced for any claim that is denied, not paid, or being audited. We handle all that. So we do definitely focus on not billing for dead patients. We do a QA. A QA is done every week on every single one of our care coordinators, which is our medical assistants. We also have LPNs. We have RNs that develop every care plan, and we also have a medical director. So that is services that are covered on our end, and we provide to our providers. So it's just extra support staff for your team. So that's why we always tell the patients that your provider is providing this concierge service for you for all his or her Medicare patients, which is a huge benefit. This is just the roles and responsibilities of, I kind of broke it down by the chronic disease solution staff, which is the staff on our end. What do we do, and what extra employees do we provide for you guys so that your team is not doing all the work? Because that, I know, is frustrating when a provider says, I really want to offer this, but my staff is tapped out. There's no way possible I can give my biller one more thing to do, or my scheduler one more thing to do, and my nurses, I mean, there's nothing more that she or he could take on. We provide all these services. All we ask for is we ask for the support, so that if the patient walks in and says, hey, Dr. Mark, we received a call from your chronic care management company. Well, we are a department of the clinic, so first and foremost, we would always say we were Dr. Mark's clinic. We always want the staff to say, yes, they do want their patients to sign up. Yes, they do believe in it, and yes, they understand the benefits to the patient. So that's probably as far as the workload that is required on the staff for a provider when we handle their CCM. What do we do for your CCM patients? These are just a few things. We provide the resources, as I mentioned earlier, such as like the transportation, the Meals on Wheels, maybe some coupons on medications. It could be like some diabetes education, some community social activities because the patient maybe get in a state of depression, so it'd be good for them to get out in the community. We provide all those schedules. We go based on the geographic area. So if your clinic's located out of Union City, Tennessee, we locate all the resources for that specific area. And we also make sure that when we call your patients, so like we're coordinating patients, appointments and all that, we're calling your patients from a local number. So if the clinic's located at Union City, Tennessee, we are purchasing a number out of that area on our expense so that we can call your patients, so that your patients only see us as being local, because remember, we're just a department at their clinic. So these are, we do medication reconciliations constantly, and we do the development of the care plan as well as the ongoing updating of the care plan. And we are also responsible for getting the care plan to the patient by mailing it. We're uploading it to the provider's EMR, as well as we are utilizing our CCM platform that we have for all of our providers. In addition to all those things, Medicare says that you only have to update your plan of care one time a year. For our providers, we update it twice a year because we do find that there's a lot that changes in 1 year. So we make sure that we do it twice a year for our providers' patients. It doesn't charge, it's not an extra cost for the provider. They don't even see anything different. It's just also an extra benefit for their patients. Any questions thus far?
Nicole, there is one question in the question box here. So you want me to read this to you?
Yes, you can. I was trying to glance at it at the same time, but I
It's
didn't
hard
want
to
to
do.
hold it.
It's hard to do. Believe me, I've been on your side of things. It's hard to read those questions and go. So this is from Annette Culpepper, and it says, Nicole, our EHR does not have care plans for all the diagnoses listed on your list. Let's see here. It's hard to read.
That's a good question.
Yeah, for
And a lot of them.
How can we access these? Is what she's asking for. And then she continues on. Also, if we have a patient on dialysis, can we call them on a day and have the dialysis? Does not mean they will not be able to be paid. So you want to try to answer those? I didn't really get that. That second one, yes. I had a hard time reading it.
Okay, the dialysis is if a patient is receiving dialysis, Medicare is actually getting billed for their care plan development and oversight.
Okay.
So those patients, I would always say it's in your best interest to just probably allow that patient not to participate while they're receiving dialysis, because your claim will be denied probably 99% of the time, because that's an oversight of care plan and they are required to do it when a patient's receiving dialysis. The other question in regards to the care plan development within an EHR, just correct me if I'm wrong, they are asking if we provide the CCM service and the provider's EHR does not have that capability, what's our step? Because we actually develop the care plan within our CCM platform, and then we just upload everything to the EMR. So your EMR can be very, very limited on the capabilities so that you don't have to pay for this big, super savvy EHR, because we do know that costs a lot. So I'm not quite sure if I answered your question. If not, please let me know and I'll go ahead and make sure that I make it a little bit more detailed or kind of explain it better.
Okay. Yeah, one of the questions was that they're experiencing audio issues. I'm not having any audio issues over here. What they may want to do is they can switch between computer audio and phone call audio. And we are recording this, so hopefully the recording will come out well. You can go back and listen to that as well. And then can Nicole send a copy of the slides? We sent you the copy. If you signed up for it, we sent you the copy of the slides ahead of time. But what I will do is go ahead and send the slides to you again. I think some people signed up at the last minute, so I will go ahead and send that to them with a link to our recording, because we are going to post the recording on YouTube after this is over. Let's see here, and I think that's all the questions that I found on here so far.
Okay, perfect, thanks.
Okay.
And again, if I don't answer your question thoroughly or correctly or in great detail, please shoot me an email. I promise it may be late by the time I respond to you, but I make it a habit that I respond to all emails within 24 hours. So you will get a response from me. And if I don't have the answer, I will definitely just let you know, hey, I don't have the answer, but I am definitely working on it, and I'll be back with you shortly. Here's the expected reimbursement rates. So I kind of in the description, you'll see the ones that are non-rural health clinics versus the rural health clinics. Non-rural health clinics, they are allowed the 99490 or the 99487. But the 99489 is an add-on to 99487. But they're not allowed to have the 487 and the 490. It's either or. But the 89 you can only have with the 87. You can't have it alone. It can't be a standalone. It's an add-on. The RHCs, the rural health clinics, are G0511. So this is, as you can see, their reimbursement was increased again this year, which is a plus. But they are only allowed to have this one code. So those other ones are the non-rural health clinic codes. What we do for our providers, though, we want to make sure that we're maximizing every opportunity for reimbursement for our revenue. So we ensure that every one of the patients that are enrolled in CCM, that they have had his or her annual wellness visit. Because we do know, of course, I mean, there's a big benefit for prevention medicine, but as well as it is extra revenue for you guys. And it helps you to kind of catch some of those issues before it becomes a chronic. So that's something we do assist with scheduling. We do help with quality measures. So I know some of you may not be held to quality measures yet, but we do make sure that we implement quality measures for every single one of our providers. If you don't have any, we just take the basic set of quality measures that is like primary care provider, so that we can at least ensure that you are ahead of the game. So if CMS decides to implement quality measures for you guys, you are already ahead of the game and meeting those. The estimated revenue, this is the estimated revenue the clinic would make after they would pay our fee. So if you had 300 qualifying patients, your annual revenue would be, this is the lowest, I went conservative, about a little shy of $130,000 a year. Because you don't pay any of the cost for it. So you don't pay for the postage, the copies, the calls, the CCM software. You don't pay for any of that. We pay for all that. We just charge a per patient per month that is billable and reimbursed. So I just kind of thought sometimes a clinic wants to know, well, yeah, that's great. I see that I'm getting reimbursed this, but what I actually make. So this is what you're looking at actually making, and this is a minimum. And I kind of put, it only includes the G0511 code. Here's your profit flow chart, just so you kind of have an idea based on each specific code and your investment. So you can see, let's just say we're handling the CCM for a rural health clinic. So G0511, they're going to get reimbursed roughly $62. We'll take 26. and then the provider is going to get the 36. So that just kind of gives you an idea of the flow, the ins and outs of the CCM rates. Any questions? Sorry, Mark, just stop me if I'm just not looking. I'm trying to glance.
You're doing absolutely fine, but there is one question on here. It says, is there specific guidelines to what each care plan needs to include to be considered advanced care planning?
Well, okay, the plan of care is a little different than the advanced care planning, which is the ACP. But I am going to actually go over into, later on, I'm going to go into the annual wellness visit and advanced directives, which is the advanced care planning. But in regards to your care plan, yes, there are certain requirements that you must include on your care plan. Let me see, I usually have it. Yeah, if you see letter B2, I have the care plan, some of the things that it must include. It has to have the physical, the mental, cognitive. So it has to have those different assessments in it. And it always has to have the goal, the intervention, and the plan. So, and it has to be constantly updated. So if the patient has, let's just say, high blood pressure. So the goal would be, let's just say the goal would be educate patient on blood pressure checks. So now what's our intervention? So we're going to provide, you know, maybe a call to the patient to discuss what is out of normal blood pressure for that specific patient. Is that patient understanding the benefits of taking his or her medication at the set time that the provider has ordered? So that's the goal, that's the intervention. Does that make sense to everyone? That has to be part of your care plan. And I'm going to say this year, Novitas, on behalf of CMS, decided to do this first annual audit. And so they chose a random, like 40 different claims for each provider, and you had to have your, you know, attestation with all the documentation. So it could be like K or L of exhibits attached to it. So it was very lengthy process because you have to show the consent, show where the conversation happened, show the actual document, show where the care plan was developed, and what is the status of each goal that was set within that care plan. And I'm going to tell you, we did successfully pass, but they were very, very detailed on it. And the care plan piece was discussed. So all those who did in fact fail, they failed because of their care plan. So whoever asked that question, very good question, because the care plan is key. If you're not, just because your EHR populates a care plan doesn't mean it's within regulations for CMS. So you have to have certain items on your care plan in order for it to meet the CMS regulations for CCM. So that's actually a very, very good question, because I think most providers assume that their EHR's care plan will suffice, and that's not the case. So we'll go back. Here's just some of the sample flyers that we, like patient informative flyer, the patient paper consent enrollment form. We do have all electronic forms as well, but I just wanted to kind of give y'all a little screenshot, a little snippet of those, some of those documents we prepare for our providers. So again, we create all these documents for our providers. We provide the training and education to their staff, as well as we assist with getting their patients enrolled via phone and or any consent that's received from the staff in the clinic. They forward it, they can fax it over to us or email it, whichever way we set it up during implementation, and we take it from there. So there's no workload on the staff's part. Here's just a screenshot of a few of our resources that we mail to the patient. Before I go to the next slide, which is annual wellness visit, I do want to also say another thing is we provide a 24/7 access to our providers' patients. we do know a lot of our providers, they're not able to provide that 24/7 access. So when their clinic's closed, the clinic is closed. But what we do is we provide 24/7 access for your patients, so they can call in. We'll conduct a triage, of course, and if it's not a true emergency, we're going to try to handle it. If in fact the provider says, no, I want to be messaged on every single patient that calls in after hours or on holidays or whatever, then we'll go ahead and message them through the EMR. If the provider just wants to wait until the next working day, then that's what we're going to do. We're going to go ahead and triage it, handle it as best as possible, just like we would during the day or a non-holiday, and then we'll go ahead and update the EMR with the call. So that's just another extra benefit that your patient has access to you. If it is a true emergency, what we do is we send your patient to the nearest ER, and we make sure that we follow up with the patient the next day so that we can start providing that transitional care. And if the patient was discharged from the hospital needing to see a specialist, we want to make sure that you are aware of that, and we help coordinate that follow-up care. Your annual wellness visit. This is something that we do assist with getting scheduled, so we want to make sure all those enrolled CCM patients do have an annual wellness visit. This just kind of breaks down their, 3 different type of, Medicare annual wellness visits. There's the welcome to, that's the first initial one, and then there's that yearly one that's the patient's been enrolled for 1 year in Medicare. And then after that, it's the ongoing GO438. So that's what we kind of, I just kind of wanted to break it down to you. Just some people are kind of, always want to ask the question, what's the difference between all the different annual wellness visits? They can only have one in a lifetime, the Welcome to Medicare, and the yearly wellness visit, which is a year that the patient's been involved. That's only one time too. And the other annual wellness visit code is the one that's ongoing after that, after those 2 have been met. Advanced directives. Yay, somebody was asking a little questions about it. What we do is we provide the documents like the power of attorney and living will. We provide those documents to the patients once we're discussing with the patient and the patient says he or she does not have that in place. We provide them with a document. We always tell them, again, this is just an extra resource that your provider is giving you. We do suggest that you go to your attorney or your family to make sure that it meets your standard. Once the patient has executed his or her power of attorney or living will, we give them a self-addressed stamped envelope. They give that back to us, and then we upload it to your EMR, and we make sure that you're aware of the patient's wishes. The DNR, do not resuscitate. We address all those things with the patient. The provider can bill for that service. We do not bill for that service because we want to make sure that the provider can get extra revenue. So that's just extra revenue on top of the estimated revenue that the practice or clinic can make. Okay, and I think I don't see any questions. I don't know, Mark, correct me if I'm wrong.
I don't see any questions on here that we've not addressed already. I do have one question. I noticed on there you're using the G0511, which is the $62 one. Medicare came out with 2 other codes or 1 other code, mental health, with a mental health component. Like I think it's like $140 or so a month. Does anybody do that? I mean, it looked like it was very hard to get what was needed for that particular code. So
thank you for bringing that up. For the behavioral health, we are in the process of implementing. We have everything implemented. We are trying to work on the one key component, and you're right, because Medicare has that gray area. What is classified as the psychiatrist or the psychologist. So you have to have a psych team as well. So we wanted to make sure, but the psychologist could have some training that would make him or her meet the psych team's standards. But we're trying to identify exactly what is considered the education, what is the specific piece that they have to have. So other than that, yes, it is a lot of work for the behavioral health piece, but it could be extremely beneficial, especially for the rural health clinics, those patients who have those behavioral health issues. We have not found anyone to be doing it. We are planning on providing it for our patients. As of right now, we're providing the service. We're just not billing for the service because we're just not quite sure if that site team, we just need clarification on one thing. And we have, the ball is actually in CMS's court right now. We're waiting for Novitas to get back with us as to, hey, this is the credentials of our site team. Please let me know if they all meet the standards.
Okay.
So we have to be very, very good.
Okay.
So I haven't crossed someone that's providing it. I do know a lot of vendors that do want to implement it, but haven't. And I'm sure it's probably because it's a lot to implement. It requires a lot of different people.
Yeah, that's
the flow chart. Yeah, it is serious.
Okay. One quick question. What about virtual visits? Have you guys have any experience in those? I know that's a new thing that Medicare is going to pay $14 for a 5-minute little a phone call. Is that a part of the services you guys provide, or can you tell us something about that?
So I'm not quite sure if they're talking about just the virtual visits or the remote patient monitoring. The remote patient monitoring is something that we are in the process of implementing. That could be great revenue for the clinic. The only thing, the expense to get it up and going could be steep, because you have to have the scale. You actually have to have all the equipment first. So we're trying to work with this one company that's going to say that company is going to give me the equipment for this one patient as an all-inclusive. So one time you're going to give me all the equipment for that patient, but I can't pass the cost to the patient and I can't pass the cost to the clinic. But if I can spread it out, so if the clinic's going to, let's just say the clinic gets $140 reimbursed, and I charge the clinic, let's just say $60 providing that, but it's going to cost me $200. Well, I may not get my money back quickly, but if I spread it out, it's not going to hit that clinic, it's not going to hit that patient, and yet I'm going to still eventually pay it off, and that patient is provided all the equipment that he or she needs for that remote patient monitoring.
Okay.
The one thing about it is ours is going to have the Bluetooth capabilities as well as the web-based, because we do know not all of those patients have smartphones. So the remote patient monitoring, the capabilities will be for those patients who do not have smartphones, as well as those patients that do. So that is something we are in the process of implementing.
Okay. Yeah, the virtual visit is more of like if I call you up and say, Nicole, I've got, this wart or something on my hand, take a picture of it, send it over to you, and you can say, Mark, you don't need to come in, just watch it for a couple of weeks and then you can come in. Then Medicare, in theory, is going to pay you guys pay the provider $14 for that, which is, it's probably a little bit out of what you guys are doing. It's really not chronic care management. It's more for an acute sort of incident that keep that patient from going into the rural health clinic immediately. So
correct.
Yeah.
So what we do provide that service for our CCM patients. We do have them all the time who send little pictures and all that stuff. They have to explain it. The only thing is we do it through telemedicine and not telehealth. So we're not seeing the patient live. That's a little different, but we do actually, we will exchange virtual pictures with the patient. So those are different. We do not bill for the service. The provider could bill and get that revenue if they like, but we find that it falls underneath the services we should provide to their CCM patients anyway.
Okay. Okay, if you have questions, you can type those in, or if you want to raise your hand and ask Nicole a question, I can open up the line for you guys and you can ask her, or like Nicole said, she's very good about getting back to you within 24 hours. That's one of the things I've been very impressed with her. I know she has a busy travel schedule and all that, but she's always gotten back to me when anybody asks me a question, and typically I will forward that question to her, and she's very, very good about that. We appreciate your time Today, looking through here, I'm not seeing any hands up. I'm not seeing any more questions going up here. So unless I see something here, I am going to close this thing down. Nicole, thank you for your help today in doing this. It's been very, very beneficial to me. I think I've learned a lot as well. And we will see you in, I guess, 2 or 3 weeks in March the 26th
Yeah.
in Alabama. And for you guys that are going to the National Association of Rural Health Clinics meeting, I will not be there. That will be the first time in 64 of these National Association of Rural Health Clinics meetings. I'm going to miss it. My child, most of you know that my child went off to college this year, and then my other, not real daughter, but she's next best thing to a daughter, is going to come home with her 3 kids, and oh my goodness, we're going to have a big time. So I canceled everything out yesterday to go to the meeting because I'd rather spend the time with them. So we will miss you guys at San Antonio, but thank y'all for attending today. We will get this recording up for you guys. So have a great rest of this day. Thank y'all very much.
Thank you, Mark, for having me.
Okay, Nicole, thank you very much. Bye, everybody.